This is Focus with Jack Caudill.
Good evening, I'm Jack Caudill. Welcome to this month's edition of Focus. This month we are talking about Colon Cancer Awareness Month, which is coming up in March. 3 guests with us to talk about that. Dr. Zakaria from Monument Health, Mike Diedrich, a former state legislator who was diagnosed with colorectal cancer, and Dr. Erik Raborn with the Rapid City Medical Center. A little background before we get too far in. March is Colon Cancer Awareness Month, also Colorectal Cancer Awareness Month. Colorectal cancer is the second leading cause of cancer death behind only lung cancer here in this country. The American Cancer Society estimates that 154,000 people will be diagnosed with colon and rectal cancer in 2025, and they say over 52,000 people will die from that disease. And statistics show that about 4% of men and women will be diagnosed with colorectal cancer during their lifetime. Dr. Zakaria, thanks for coming up. We're going to start with you. When we talk about colon cancer, colorectal cancer, what are we talking about exactly?
Yeah, thanks for having me here today. And this is a really huge thing. And I had so much passion about this topic in particular about, colon cancer awareness since I moved to the Black Hills area almost 3 years ago. And it's a very important topic, especially with the amount of cancers that you just mentioned, the incidence, the mortality, and the percentages that we've been seeing lately. So colon cancer is basically a tumor or a cancer or malignancy that happens in the GI tract or the last part of the GI tract, which is basically the colon. And we call it colorectal because sometimes we kind of differentiate between them, where we call colon cancer is within the colon itself and the rectum is the last part of the colon. We call it rectal cancer. So sometimes you will see different statistics and different kind of numbers for rectal cancer and colon cancer, but collectively we call them colorectal cancer. And the reason for that is somewhat like the workup and the diagnosis and the staging and the treatment can be a little bit different between them, but the way of approaching them in terms of diagnosis and screening is the same. So when we talk about colorectal cancer screening or evaluation or pre-cancer stage evaluation, is that we approach them collectively at the same way.
Now, Dr. Raborn, when you talk about colon cancer and colorectal cancer, are there different types of cancers that you guys find?
Yeah, absolutely. So colon cancer is an umbrella term for a whole bunch of different types of tumors that can grow and cause issues in the colon and rectum. The best way to detect and remove these things is through a colonoscopy. It's the only tool available that can both diagnose and treat at the same time. The way that colon cancer can present in a lot of people is very different. Symptoms can be very vague, and the important things in here is that it should never be considered normal to have any bleeding issues. Okay, that always deserves further treatment and evaluation. I find often that, especially in younger populations, especially in young men, that a lot of these symptoms get ignored for long periods of time, which puts you at higher risk of being diagnosed further down the process. Whereas if we can catch things early, we can remove them via endoscopy, and a lot of these patients don't even require surgery, chemo, or radiation afterwards if they're caught early enough.
Now, Mike Diedrich, we mentioned you were diagnosed with colorectal cancer in 2022. What is your story? How was yours discovered, and where has that journey taken you since that point?
Well, part of my story is I'm what you should not do. So if any message I can get out to men and women in our community and throughout the country to get tested and look for symptoms and go for early care is important. I neglected that. I was too busy. I was doing legislative work. I was doing healthcare work, doing lots of work in the community, and there's always something I'll schedule that later. Well, it turns out I ended up getting blockage and came in for issue related to that. I was blocked up, throwing up, stomach up, and we determined that we had colon cancer at that point in time, and Dr. Zakaria was saved me twice. Has saved my life twice. He diagnosed me. He performed a surgery in October of 22. And I did chemo for about a year and did along with Dr. Azuka. And the clinical trial drug turned out to be successful, and I was in remission a year later in October 23. And then 3 months later, I had another issue and it had returned. But with the care, as I'd go through at least five different chemo treatment drugs, with that care, I managed to just level out and not grow aggressively. So I'm fortunate that I got recognized at the time I did, and I'm able to share that message. I mean, to anybody who's watching, go get checked and don't take it lightly.
Dr. Zakaria, he's talking about screenings, the importance of those. Who needs to get those?
Yeah. So usually when I approach, I'm glad that Mike sent that message, hopefully loud and clear for the community, that please go and get checked. And the way that I actually approach colon cancer screening, there is three ways of you presenting for colon cancer screening. Either as an average risk individual who got to the age that you should go for screening, you visited with your primary care physician, and he said, well, part of our health maintenance is to recommend that you get colon cancer screening, and you should be checked, either by different way of doing that. We can talk about that in a minute. Or, like Mike, he came in, unfortunately, emergently, with acute bowel obstruction to the emergency department, throwing up, couldn't take anything orally, and then the diagnosis was found that way. And then there's the in-between, that you're not really asymptomatic and you're not emergently presenting, and that's what Dr. Raborn just mentioned, is that you have lingering symptoms, but you're trying to ignore it, so don't. So those are the three ways of presenting for colon cancer. And we really want everyone to get tested before symptoms, or to get screened before symptoms. And when we recommend screening, we just want to talk about average risk. The average population, you're healthy, you have no issues, or you have minor comorbidities, you just got to the age you're supposed to go and get colon cancer screening. And the average risk individual is any adult at the age of 45. So if you're 45, it's time to visit for colon cancer screening. And you can do that through your primary care physician, or you can go for a gastroenterology visit for a procedure screening type, and you go from there. Certain group of people, they require more attention. For example, if you have a family history of colon cancer, for example, when I talked to Mike, when we got him diagnosed, my message was him, okay, your kids need to be very well aware of that. Their risk is more than the general population. Now, they are not average risk, they are actually high risk because of first degree relative with colon cancer. And the screening should be 10 years younger than the age he was diagnosed, or at the age of 40, whichever comes first. So all of his kids or his offspring should be more aware and should get screened sooner. Also, people who have genetic predisposition, if you have a genetic disease that predisposes you to colon cancer, there is so many of them, and each one of them has special recommendation when to start and when to stop, and how often do you do your screening. We're fortunate enough at Monument Health with a multidisciplinary kind of approach. We have a genetic counselor. So she sees the patient, she do the proper counseling, she does the genetic testing, and if the patient has a high risk, then they come to my genetic predisposed or polyposis syndrome clinic, where I actually see them and then evaluate what the GI recommendation should be from multiple organs, including colon cancer. Also, patients with inflammatory bowel disease, after 8 years of diagnosis, they are at a higher risk because of the chronic inflammation. So the recommendation is different, but the message for average risk, you're 45, you're average risk, you just need a colon cancer screening. Go and get it. So at the 45, go get it. If you hear that your dad, mom, brother, sister got colon cancer or advanced adenoma, ask them when they got that diagnosis. 10 years younger or at the age of 40, go get checked.
All right. Dr. Raborn, he mentioned 45 was the age that's lower than it used to be, the age for recommended to start getting screened. Why is that?
So the data that we've been evaluating over the last 10 years, we came out with new recommendations, and essentially younger persons are getting diagnosed with more advanced polyps, and more often they're getting colon cancer at younger and younger ages. I know that in Rapid City Medical Group's GI group, we've diagnosed multiple cancers in people under the age of 35 coming in with symptoms. And so this is an important group to target and care for, because the reality is nowadays with excellent care, there's no reason that you shouldn't expect to be able to live to be 100, and it should be a good 100. And I think avoiding colon cancer and potential comorbidities associated with that is an important part of that process. I also wanted to add on to what Dr. Zakaria said in regards to making sure you get your screening done. People can call us directly at the endoscopy center and get set up for a colonoscopy without a referral. You just have to call and say, I need to get screened, and we can set you up directly. You don't need to go through any other sources.
All right, we got to take a break. We'll continue our look at colon and colorectal cancer when we continue with this month's edition of Focus. I'm Jack Caudill. Welcome back to this month's edition of Focus, talking about March being Colon Cancer Awareness Month and Colorectal Cancer Awareness Month. Mike Diedrich is with us, a former state legislator, was diagnosed with colorectal cancer in 2022. Mike, do you remember, what is that emotion like, that shock like when you find out it's cancer?
It is a real shock. It hits you kind of like a ton of bricks, and you realize instantly how little you know about the proper health care and the proper procedures to go after that. And so, it totally interrupts your life too, as well, because of the way you feel or the way you react to chemotherapy or whatever type of treatment you may be going through. On the other hand, so you got this kind of shock and horror. Me, what's that going to be? What am I looking at? I only know what I've seen on TV shows. Mm-hmm. You got that unknown. At the same time, to meet and learn and know about the incredibly talented oncology and GI physicians that we have in our community, and all the patients who are benefiting from that, and from all the different trials, and the patient is always guiding whatever they want as far as the treatment, but they get great advice. They've got all the finest physicians doing it. We have, I've had the opportunity to go elsewhere for additional treatment. We checked it out. We have no need to. We have a great community care here. In fact, I'm blessed that I live in this community. And I hope that the young people or those who haven't had their test recognize that, because you don't want to get that ton of brick stuff, but you want to feel that you're blessed by having great care available.
Dr. Ali Zakaria with Monument Health. And Mike said earlier, he put off his screening past where he should have done that. What do you know about screenings? Are they as imposing? Are they as ominous as a lot of people think they are?
Yeah, which is unfortunately, that's like the misconception that most people, they think it is actually invasive procedures. I don't want to do it. I want to just delay it. I heard my friend or a family member or a neighbor had like a rough time doing that procedure, or they had like, bad experience in the past, or a family member somewhere had a complication from the procedure. I think when we talk about colon cancer screening, people, they understand that there's so many tools available for them. And there is actually guidelines recommendation, which one should be offered to the patient, and what is like tier 1, tier 2, or which is better. Some of them are only diagnostic, meaning that they will tell you if you have or likely having a colon cancer or not. And then they are sensitive, good tests in terms of their sensitivity and specificity. And there is diagnostic and potentially therapeutic tests, like invasive tests that we all know as colonoscopy. So the way that I look at it is either that we do a stool-based test or a visualization test. I look inside your colon or look at the colon by either imaging or endoscopy. The stool-based test, there is two types of them, either the FIT test or fecal immunohistochemistry test, and that's a annual test that you just sit a stool sample and they test it. If there is, if that's positive, when it's positive, it tells that most likely you have colon cancer or you have possibly advanced adenoma, but it's meant to detect colon cancer. There is false positive rate where it can be positive while you don't have a colon cancer. So positive doesn't mean that you're 100% colon cancer. It's just more likely to have a colon cancer than not. And there is the other newer multi-targeted DNA test, which has a FIT test and DNA detection as well, or mutation detection. The known name for it, or the generic name, is Cologuard, which is the blue box, some people they call it, that they ship to your home. You do a test, you ship it back, and then they come back with a positive or negative result. There is a second generation of that test, which is even more sensitive, so the results are getting better and better, and less false positivity. That's a test that you can do every 3 years. So you can just put a stool sample. If it's negative, you're good for 3 years. Unless, of course, you have symptoms. We're talking about screening. We're not talking about symptomatic. If you have a strong family history, if you have symptoms, don't do stool test. Go for the proper diagnostic test. And then the visualization test, either colonoscopy or imaging by CT colonography, or you do a CT scan, and then the CT scan, if there is any polyp or mass, will tell, and then you have to do colonoscopy to look at it and biopsy it. Colonoscopy itself is actually very well tolerated procedure. I usually tell my patient that the rough part is the night before, where you have to take the bowel prep, and we even got better with the bowel prep. You used to drink a gallon, and one time, like you have to drink a gallon at a certain amount of time. Now we do a split prep, where you drink half of it the night before and half of it a few hours before the procedure. And then we got new generation bowel prep, which is smaller volume. Even we start having pills, that you can take pills with water to clean you and get the test done. The prep is essential because I can't go in and do a colonoscopy while there's a lot of stool. I really need to get a very good prep so I can see everything, and if there is any polyp or mass or a lesion, so I can remove it. So we got better in the prep, we got better in our technique, the new technologies and the AI system, the cameras that we use are extremely advanced, that we can see very tiny little lesions up to 1 millimeter, and we can remove it right then and there with the colonoscopy. When you come into the colonoscopy, our team in the pre-op area are very friendly, trying to put you at ease, prepare you. The anesthesia will take care of you, talk to you. At Monument Health, our approach is doing monitored anesthesia care. So there is an anesthesiologist and certified registered nurse anesthetist who can actually put the patient comfortable during the procedure. And most people who had colonoscopies many years ago and who have been having it recently, they can tell the difference. They're more comfortable, they sleep right away, they wake up right away, they don't remember much about what happened during the procedure, and then we meet them in the post-procedural area. And I will tell you, lately I've been hearing more people saying like, oh, that was not bad, especially when they wake up from the procedure.
All right, Dr. Erik Raborn is with Rapid City Medical Center. Like Mike, I was diagnosed with colorectal cancer in 2022. At that point, I have never had any symptoms that anything was wrong. Is that unusual at all?
So a lot of it is dependent upon where the colon cancer is located throughout the colon, as well as what type it is within the various subtypes that you'll have there. So, right-sided colon cancers on this side of the body tend to get diagnosed later due to the fact that you have more liquefactive stool on this side and they're not causing obstructions. It's more typical that when you present with obstruction, it's more of a left-sided cancer. And it's actually interesting is that very often the treatments for these are approaches, and the genetics for these two typical presentations are also very different, leading to different choices and selection of chemotherapies and radiation and all kinds of other elements between the two halves of our colon.
All right, we got to take another quick break. We'll continue our look at colon and colorectal cancer when we continue with this month's edition of Focus. I'm Jack Caudill. Welcome back to this month's edition of Focus, talking about colon cancer and colorectal cancer Awareness Month. Dr. Erik Raborn is with Rapid City Medical Center. We talked about screening, we talked about detection, but what about prevention? Is there anything you can do along the way to lessen your risk of cancer?
So the biggest correlations that we have lots of good data for are tobacco consumption of any sort, including vaping. And alcohol consumption. Both of these independently and together actually put you at a significantly higher risk of developing not only colon cancer, but esophageal, stomach, pancreatic, and liver cancer as well.
Are there, as far as getting checked out, what is the difference between finding this now and finding this a year later, 2 years later, 3 years later?
Yeah, so of course, having the diagnosis early will put you at an earlier stage of the disease, and the earlier the stage, the more chances of curative treatment options will be. So for example, if you start having symptoms, abdominal discomfort, bleeding, then I go in and I see a polyp, even if that polyp is big, back in the days, a bigger polyp used to go to surgery. Now with the newer techniques and the interventions that we have, I can actually take as big of a polyp as it can be possible, and as long as it doesn't have cancer. So you can remove those polyps before it becomes cancer. So that's the first stage. Then if it is cancer, and it's not, it shouldn't be removed endoscopically, then okay, we do the staging and it's an early stage. Then you do a surgical resection, you take the lymph nodes around that area, and if that's an early stage, like for example stage 1 colon cancer, then you're cured. You don't even need chemotherapy. So And you don't even need surveillance images or whatever. You just need another colonoscopy in a year. So the early stage, the curative rate is high, the prognosis is excellent, and the trauma that comes with the treatment will become less because it's just a surgery that you will hopefully recover from and no more complication. While if you waited till you come in obstructed, then it's already metastatic disease, you have lymph nodes, you have liver lesions, then the chances of the prognosis get worse, the treatment success will become less, and it's more of palliative, controlling the disease with no cure intention. We cannot cure it at that point. We can control it, not cure it. So early stage is curable. Late stage is controllable, not curable. That's why do it as soon as possible. Do the screening, follow up the screening recommendation. If your initial screening shows polyps that you require more frequent interventions, do more frequent interventions. If you end up doing a stool test and it's positive, get a diagnostic test. Do the screening colonoscopy to look why it is positive. Don't wait.
Dr. Raborn, how are we advancing as far as detection and treatment? How much better is that now than it was 5 years, 10 years ago? Where are we going in the future?
The big thing with advancement in it is the expansion of options and simplicity in options for getting people screened to ultimately get them to the colonoscopy if it's indicated. So having the stool studies makes a big difference, and we're also developing in our research arm right here in Rapid City a blood test to help detect colon cancer earlier in at-risk individuals as well. And so having options that are convenient, that get people to the ultimate therapy that they need, is probably the biggest part of advancement in terms of detection that's available now.
All right, Mike Diedrich, a former state legislator diagnosed with colorectal cancer in 2022. What message do you have for people to take away from all of this?
Well, my message is go in and get tested, get screened, do whatever it is early on in accordance with what is recommended, or if your family has an indication, do it earlier than that. We have an incredibly talented medical staff and a physicians community that help through the treatment options that are out there, but you don't have to do as many of those if you get it caught early. So do it for your family, do it for your church, do it for your community, and do it to help our team so they can continue to work on cutting edge research and clinical trials, things like that is going on. But they also they handle the patients, they handle the research, they're guiding our community and protecting our community. And so let's help them out by going in and being a specimen.
All right, we got just a quick bit of time. You were talking about a cancer workshop that you were talking about earlier.
Yeah, there's a cancer workshop, if you could show me. I brought these flyers. A cancer workshop on March 11th through April 15th on Tuesdays at 12 to 2:30 p.m. at the Cancer Institute at Monument Health. And it helps patients and caregivers manage their symptoms to be able to share information and help the community be healthy.
I got to cut you off. We're out of time. Dr. Zakaria, Mike Diedrich, Dr. Raborn, thank you for joining us, and hope to see you again next month for another edition of Focus.